We'll be discussing the urodynamics. It is a very important topic, mostly important for the IMM, also important for your FCPS theory, Mrcog theory and clinical. In clinical, you can get it as a station where you have to interpret the urodynamics and then you have to follow the management plan for that certain urodynamic chart. So you should know how to interpret the urodynamics. The other station you can get is you have to do the teaching for the urodynamics, right? So before going to details of the urodynamic, we will shortly discuss about what actually is urodynamic, what is its definition, what it actually assesses in the bladder, and what is its importance. Before going for urodynamic, how you have to prepare your patient, how to take the consent. All these things will help you in your talks management station as well, not just teaching but also for your other urodynamic stations, like if you get stress urinary incontinence, how you will counsel the patient, how you will proceed with the urodynamics, what are the indications for urodynamics. And it can also you can also get it as a case-based discussion. In this case-based discussion, the examiner can ask you different questions. So let's start with the topic. Try to follow it till the end so you have the complete gist of this topic, and you should be able to teach others as well. You should be able to know about the prerequisites. You should be able to know about the interpretation, contraindication, consent procedure, all the prerequisites. And in the end, you should know what are the components of a urodynamics, right? So it includes actually all the measurements that assess the function and dysfunction of the lower urinary tract. Now, what are the lower urinary tract functions and dysfunction? First is the storage, then the voiding, post-micturition symptoms. So these are the lower urinary tract symptoms. First one is the storage symptom, then the urinary urgency, nocturia frequency, and urinary incontinence. So storage symptoms is the most common of all the urinary tract symptoms. In storage symptoms, if we see the urgency, it means that you have a strong desire to pass the urine. Nocturia means you are waking up at night to pass urine. All these are your history point also, okay? Frequency, you have to ask your patient if she is passing more than 8 times per day, then it is a frequency. If more than 1 time at night, then it is also a frequency. Urge incontinence or urinary incontinence, it could be stress or it could be urge incontinence or it could be mixed incontinence. Means that the patient has the urgency to pass urine, but there is involuntary leakage of urine and she is not able to control her urine. Now coming to the voiding symptoms, these are also the lower urinary tract symptoms. It shows the slow stream, the hesitancy, straining, like starting of the urination process is difficult in hesitancy. Now the post-micturition symptoms are the sense of incomplete emptying, post-micturition dribble. Now the urodynamics will tell you about all these functions of the lower urinary tract. Mostly the cystometry will tell you about the storage symptoms. The uroflowmetry will tell about the voiding symptoms, okay? Now there are the basic requirements for a certain urodynamic to be done. So for a urodynamic, it should represent a uroflowmetry with post-voidal residual volume. It should have a transurethral cystometry and pressure flow study. All these are done when patient is seated or in a standing position, right? So for a urodynamic to be complete, all these 3 studies should be done. We will be discussing them one by one, okay? But before going towards the further details and interpretation, there are certain prerequisites that you will incorporate in your teaching station as well. There should be a targeted urogynecological and clinical history and examination of the patient. The consent should be taken from the patient, because it is very important that you should tell your patient about the procedure before hand. This procedure should be done when the patient is relaxed, the patient is not anxious, and the patient is not okay. Now and the patient should be knowing about the procedure beforehand, and when the patient consents completely, understand the procedure, then only it could be more near to the physiological parameters, right? Then the bladder diary is very important. You should keep the bladder diary for at least 3 days. Now what this bladder diary will help you to tell? This bladder diary will help you because it is useful. The examiner can ask you this as well. So bladder diary is useful, non-invasive method of obtaining information on the fluid intake, episodes of incontinence, pad usage, and the timing of the volume voided, or the amount of the volume voided also, right? Now apart from that, the current medications are very important to be asked. If the patient is previously using any medicine for the overactive bladder, then you should ask them to stop these medicines 1 week before the urodynamic test. But nowadays they say that it is at the discretion of the clinician whether they want to stop the overactive bladder medicines or no. There should be a documented report whatever medicine they are using for the overactive bladder. And then you should also tell about the thing that you will be providing the patient information leaflet for the better understanding of the patient about the procedure. And there is a leaflet available at the International Continence Society site also. Now you have to stop the antimuscarinics prior to the urodynamics. Okay, this is the preparation of the patient. Urine dipstick must be done before the urodynamics to check for the infection or hematuria. Whenever there is hematuria or when there is an infection identified by the urine dipstick, then you should first treat the urinary tract infection and then go for the urodynamic test. Till it is completely cured, you should postpone performing the urodynamic test. Again, along with this procedure, there is a self risk of urinary tract infection. So you should make sure that you are doing this procedure under aseptic measures, right? Aseptic conditions. And whenever you are performing all the invasive components of the urodynamic testing, then you should be using the aseptic measure. If there is any evidence of prolapse, then this should be reduced using pessary, speculum, or the finger. Now you should be very clear about the indications for the urodynamic testing. These are very important because once you want to go for the urodynamic test, there should be a certain indication. Okay, this is what you would be telling your examiner, this is what you would be telling to your patient in the routine practice. So the urodynamics is used for the overactive bladder and the urge predominant mixed incontinence. But for the urge predominant mixed incontinence and overactive bladder, for both of them you will use it after the failure of the initial conservative treatment and invasive treatment prior to surgery. What does this mean? This means that first, if a patient is with overactive bladder or urge predominant mixed incontinence, means she has more symptoms of the urge predominant, then she has taken the initial conservative treatment for herself. If this conservative treatment fails for this condition, then you go towards the invasive treatment. Okay, most likely it is the botulinum toxin. Okay, so before this, the Botox injection, you have to offer the urodynamic to your patient. Okay, and then before surgery you have to offer. Now if the patient is undergoing primary surgery for stress urinary incontinence, it means for the first time she is undergoing the surgery, then the urodynamic is not indicated. That is, the multi-channel filling and voiding cystometry is not indicated. Okay. Now you can only, for the stress urinary incontinence, you can only perform the urodynamics if the urge predominant, mixed incontinence is there, or urinary incontinence type is unclear. These are the conditions. The symptoms are suggestive of voiding dysfunction. The voiding dysfunction we already discussed. There would be hesitancy, there would be poor stream, okay. And if there is anterior or apical prolapse, if the patient is having stress urinary incontinence along with the anterior or apical prolapse, only then in the patient with stress urinary incontinence you are going to have the urodynamic testing. And if there is a history of previous surgery for stress urinary incontinence, still you have to go for the urodynamic testing. So let me explain again about these things. Urodynamic indication should be very clear to all of you. Okay, the first one is the overactive bladder and urge predominant. For stress urinary incontinence, you have to do it for these certain indications, otherwise you are not going to do. Okay, now the components of the urodynamic testing. The first component for the urodynamic testing is the uroflowmetry. Uroflowmetry is a simple and non-invasive and inexpensive test. It is the first line screening test. It will tell you about the three things. First of all, how much of the urine is passed per unit time. How much urine is passed per unit time in ml per second. What was the maximum flow rate, and what was the post-voidal residual volume after the micturition, right? So what amount of urine is passed in ml per second, what is the maximum flow rate, and what is the post-voidal residual volume. So the maximum flow rate is up to 20 to 36, okay, and this is around 15 ml per second. But this should be if a person is voiding 150 ml of urine. If a patient is voiding less than 150 ml of urine, automatically this is going to decrease. Okay, so 15 ml per second is for 150 ml of urine. And what is Qmax? Qmax is the maximum flow rate. Okay, once the stream is established, then what is the maximum flow rate? And post-voidal residual volume less than 100 is okay if a patient is asymptomatic, otherwise less than 50 we take as a target range. Now this is the Qmax. It is usually a bell-shaped curve, but it needs not to be it's not necessary for this curve to be in a proper manner. It can be asymmetrical, right? But it is a bell shape like this. This is the Qmax, and this is the proper stream. It is going up, then the maximum Qmax is reached, and then it is going down. Now these are the patterns of the uroflowmetry descriptions. I already told you, if it's a steady rise and then Qmax is reached and then there is a fall. But if you see several peaks in Qmax, it means that the patient or the person is having repeated Valsalva manures, means straining, increasing the abdominal pressure, because the flow is not going out properly. So because of that, we see this kind of graph. It means that there is some bladder outflow obstruction which the Valsalva manure and straining is trying to overcome, or sometimes there are unsustained detrusor contractions. So in these cases, the graph would be like this. If there is reduced Qmax mean it could be due to urethral stricture. There is no proper bell shape curve and there is no Qmax. It is just like a bell shaped structure. And very high Qmax could be there. It is due to the possible detrusor overactivity or high speed squirting to overcome an obstruction. Okay, so these are different type of patterns of the uroflowmetry. This is important because sometimes they can give you in your clinical exams about different shapes and types of curves, and they can ask about that. Okay, now coming towards the normal cystometric findings. This is very important. You should know about the normal bladder capacity, the amount of the urine a bladder can hold. First desire to void. First desire is when first time you feel the urge to pass urine. Strong desire is usually equal to the maximum cystometric capacity. Maximum cystometric capacity means the maximum amount of urine a bladder can hold. So when there is a strong desire, usually we say that this is the maximum cystometric capacity. The other one is detrusor pressure. The detrusor pressure during filling is less than 15. You should keep this thing in your mind that during the filling phase, that I will explain in a while about the urodynamics, that what is especially the cystometry, that there is a filling phase, there is a voiding phase. So we will be discussing one by one, but for now you should know about this thing, that during filling phase the pressure should be less than 15 for detrusor. There should be no rise in the detrusor pressure during filling, and the voiding it should be less than 70. But if during voiding it is going high up, that is more than 70, it means that it is overcoming some obstruction or detrusor is hyperactive. Abdominal and vesical pressure is usually 5 to 50 centimeter of water during filling also. Okay. Now cystometry. Now cystometry is the test to assess the bladder storage ability. Okay, in this test what we do, we take one vesical catheter to insert into the bladder. Usually a 5 to 7 French catheter is used, and it is used to measure the pressure vesicle, right, pressure bladder. Then a rectal catheter is placed to measure the pressure abdomen. If a rectal catheter cannot be placed, then you can use a vaginal, or if a patient is having stoma, then you can use stoma to place this catheter to measure the abdominal pressure. The detrusor is automatically achieved by subtracting the abdominal pressure from the vesical pressure. So this is very important for you. This could be an exam question in your Mrcog and your theory FCPS also. I already told about the first sensation of bladder filling. The moment the patient feels that their bladder is no longer empty. This is called first sensation. First sensation when you feel the bladder is no longer empty. The first desire to void is the moment that normally tell the patient to go to toilet without any hurry. Okay? The first sensation that you feel the bladder is now no longer empty. But first desire is that you feel that you need to go to toilet, but there is no hurry. The strong desire that I already told you is equal to the maximum cystometric capacity. The moment the patient feels that they will lose urine, okay, and they cannot postpone the voiding and will visit the nearest toilet. Feeling of urgency. So this is the feeling of leaking or fear of leaking or pain or any other symptoms. So during the cystometry, a patient is asked to cough every time and every minute to assess the recording quality. So I will be telling you in the normal cystogram that how this cough is interpreted. But whenever the patient is coughing, there is a rise in the abdominal and vesical, but there should be no rise in the detrusor activity. Okay, this thing you should keep in mind. This is very important for the purpose of the concept, that if patient is coughing, the pressure vesical and pressure abdominal will be rising, but no rise in the detrusor pressure. Okay, no rise in the detrusor pressure. Bladder compliance is another term you should be aware of, that there is the association between the rise in the bladder volume and change in the detrusor pressure. Normally, if the bladder is compliant, how you will take this concept? If the bladder is compliant, it means it is storing a lot of urine, right? Normal compliance is we see the maximum cystometric capacity up to 500, right? 550 to 500. But if it is storing more than the normal amount of urine, it means there is something wrong with the detrusor. With more than normal amount of urine, still it is not contracting. It means that the bladder is having higher compliance and detrusor is having underactivity. But if with the small amount of urine the bladder start contracting, that is less than the normal cystometric capacity, it means that the bladder has less compliance and detrusor is overactive. I hope this is clear up till now. Now these 3 points should be on your fingertips. That during the filling phase means when the bladder is filling. During the filling phase, the detrusor pressure should never rise. Okay. If the detrusor pressure is rising during the filling phase, it means that this is not normal and this is called detrusor overactivity. Usually what we call the overactive bladder when the patient is having symptoms of urgency and frequency. But once it is confirmed on the urodynamic, then we call it detrusor overactivity. So for a normal cystometry, the detrusor pressure should not be rising during the filling phase and it should remain less than 15. It should remain less than 15 centimeter of water. Okay. Okay, now the stress incontinence. The stress incontinence also the detrusor pressure is not rising. There will be rise in the abdominal pressure along with the vesical pressure. Both the pressures are normally 5 to 50 centimeter of water. If during filling phase they are going above this one, along with the leakage of urine, along with the leak. So what is the difference between stress urinary incontinence and cough? That I will be showing in a while, but take this concept for now, that whenever you ask the patient to cough, there will be a rise in the vesicle, a rise in the abdominal pressure, but there will be no leak. Okay, this is the cough. But when you ask the patient to cough and the intra-abdominal pressure is increased and the vesical pressure is rising, abdominal is rising, no change in detrusor, no change in pressure detrusor, and there is leak, it means that it is stress urinary incontinence. But if detrusor overactivity, if there is rise in the detrusor during filling phase, but along with this rise in the detrusor and the leak is seen, then we call it urge incontinence. Okay. This is normal graph. Now I will explain to you. This is the filling phase, right? This is the filling phase. These are the pressure in centimeter of water. Can see? This is the pressure. Not this one is not the pressure. This one is the pressure, right? So it is in the centimeter of water. This one is the vesical pressure. It will always be same in all urodynamics, right? So there are two phases in the urodynamics. This one is called filling phase. Okay. This one is called voiding phase. Voiding phase start once the maximum cystometric capacity is reached. Once the bladder is full, it starts voiding. So during filling phase, normally you see here the abdominal, the vesical and the detrusor pressure are not increasing. And there is this one, this is just seen here. This is called cough. You can see it. They have already demonstrated it or labeled it as cough. So in a urodynamic, you can see this is cough. It is corresponding to the rise in the abdominal, the rise in the vesicle and abdominal, but there is no leak. Here they will demonstrate leak. So in filling phase you can see no leak, but in voiding phase you can see the leak. So this is the rise, okay, and now there is no leak, so it is a normal urodynamic. This one is the first desire to void. This one is the strong desire to void. This is the maximum cystometric capacity. Now for the purpose of simplicity, I have made these diagrams myself to teach you to get the concept. This was the filling phase, this is the voiding phase. Okay, this should be the flow, which is usually called the Q. So when the vesical pressure is increasing, what is the difference between the cuff and the stress urinary incontinence? In cuff, the abdominal and vesical are increasing, but there is no leak. But when you see that the increase in the vesical and abdominal is corresponding to the leak here, it means that it is the urodynamic stress urinary incontinence. Okay. Now, here you see, there is no change or rise in the vesical, no change in the abdominal, but there is rise in the detrusor pressure. It means that this is detrusor overactivity, but there is no leak. If there is flow or leak, then it is urge urinary incontinence. Now, there is one more term. It is important for your MRCOG questions and for your clinical as well, that what is the difference between urgency, that is the detrusor overactivity, and sensory and urgency. So they will be giving you one question, what is called sensory urgency and what is detrusor overactivity. So how you will differentiate between these two terms? In sensory urgency, there will be no increase in detrusor pressure, no increase in the detrusor pressure, but patient will have urgency. The detrusor pressure is not increasing, but if the maximum cystometric capacity is somewhere around 500, she will start having the urge to pass urine at 150. But when you do the urodynamic, there will be no increase in the detrusor overactivity. But for detrusor overactivity, there will be increase in the pressure detrusor. These are all the important things I have covered for today. If you have any other questions or you want to ask about any questions, you can comment in the chat box or you can post your comments. Whatever topic you want me to teach you, I will teach you, and you can drop it in the comment box. Okay. And tomorrow I will be uploading another video which would cover the teaching station for the urodynamics. These were just the basics because these were important for your clinicals of the FCPS as well as for your question solving in MRCOG 2. And now tomorrow I will be teaching you the station, that how you will tackle the station if you get the urodynamic as a teaching station. Okay. Thank you all.